Hello, I'm Dr. Stephen Dahmer. Very excited to be with you today to discuss this timely topic, medical cannabis. The title of this talk is Clearing the Haze, Guidance on Medical Cannabis for Chronic Pain and Other Conditions. I want to offer a land acknowledgement. We respectfully acknowledge the University of Arizona is on the land and territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The university strives to build sustainable relationships with sovereign native nations and indigenous communities through education offerings, partnerships, and community services. I'm the director of the Andrew Weil Center for Integrative Medicine. I'm the Andrew Weil Endowed Chair in Integrative Medicine. I am Division Chief in Integrative Medicine and Associate Professor of the Department of Family and Community Medicine, as well as the Assistant Dean of the College of Medicine, Tucson, for Wellness. I'd like to go over this slide on disclosure and disclaimers. I was previously employed and contracted by Vireo Health Incorporated. Cannabis is still designated alongside heroin as a Schedule I substance under the Federal Controlled Substances Act of 1970. The statements made regarding these products have not been evaluated by the Food and Drug Administration. This is an off-label investigational discussion. The only FDA-approved use of CBD is for pediatric epilepsy. All other uses are not FDA approved. The FDA has not approved the cannabis plant for any medical condition. The cannabis plant and plant-derived substances remain illegal at the federal level. AzCANN is a cannabis education program delivered by U of A Comprehensive Center for Pain and Addiction. This program is supported by grant number CTR 063305, funded by the Arizona Department of Health Services. The contents are solely the responsibility of the authors and do not necessarily represent the official views of ADHS. We're very appreciative of the remarkable illustrations by Galandara. More on Galandara can be found at www.galandara.com. And this presentation is a collaboration between the Comprehensive Center for Pain Addiction and the Andrew Weil Center for Integrative Medicine. Course objectives are to understand the role of medical cannabis in chronic pain, to apply harm reduction and personalized medicine principles, and to navigate legal, research, and risk considerations. The agenda, first we'll talk about botanicals and cannabinoids, then we'll do an evidence review, we'll speak of counseling on cannabis as a therapeutic, and then we'll speak on counseling on cannabis treatment risk. Provider competencies in a clinical setting, we'll speak to botanicals and cannabinoids. What we do know about medical cannabis and providers. We know that in a cross-sectional study of internal medicine residents from Mount Sinai and Morningside West, about 86 internal medicine residents, 93% felt they had inadequate knowledge regarding medical cannabis. Virtually none knew indications or contraindications, and very few had any knowledge of dosing. We also know that 91% of American adults support the legalization of medical cannabis. This is the one thing across the board that Americans we seem to agree upon. 81% of physicians in the U.S. support the use of medical cannabis when recommended by a doctor. What are botanical medicines? Definition and scope. They are plant-derived substances used for therapeutic purposes, encompassing a wide range of herbal remedies, traditional medicine, and natural products. There's a rich historical context where the use of botanical medicines has a long-standing tradition, roots dating back thousands of years across various cultures and civilizations. There are estimates that as many as 25% of prescription drugs come originally from plants or plant-derived, and over 4 billion people in the world incorporate whole plant extracts into their primary care. 400,000 plant species exist, with 14,000 traditionally used in primary health care. And we're only scratching the surface of only 1 to 2% of the world's flora that's been thoroughly screened for medical potential. The argument here is that botanicals are an important part of even modern medicine. Here are a few examples from vinblistine, vincristine, coming from Catharanthus roseus, the Madagascar periwinkle, to Tamiflu, coming from star anise, to quinine from the cinchona tree. Many important medicines are derived from plants. Cannabis in the whole plant form is also a botanical medicine. And it is important to recognize the varieties of cannabinoids that exist. The endocannabinoids, or the endogenous cannabinoids that our body produces ourselves. This is a growing area of research that is rapidly identifying newer endocannabinoids every year, a few of those being AEA, 2AG, and ADA. There are the phytocannabinoids that come from plants. We'll be speaking of THC, CBD. We'll speak less to minor cannabinoids, CBG, CBN, and many of the others. And then there are the synthetic cannabinoids that come from the lab, including our FDA-approved synthetic THC nabilone, and then synthetic street drugs including K2 and others. Botanical medicines have phytochemical complexity. When we speak of medical cannabis, we're speaking of over 100 different cannabinoids, hundreds of terpenes in varying levels. These are aromatic and flavor components of the plant. And there is a hypothesis that this entourage effect or ensemble effect is that the combined effect of the types and amounts of cannabinoids, terpenes, and other constituents in a given cannabis product may impact humans' physiology different than a single constituent. And it's curious to look at the cannabis plant itself and the two major cannabinoids, those two cannabinoids most prevalent within the plant, THC and CBD, possess a natural botanical antagonism. THC in high enough doses can be associated with euphoria, anxiety, even psychosis, cognitive impairment, and tachycardia. And we see CBD with an almost opposite effect. In specific dosing can impact euphoria, can act potentially as an anxiolytic, as an antipsychotic, can have neuroprotective effect, and can impact bradycardia. Market cannabis versus traditional pharmaceuticals, there's a marked difference. Pharmaceuticals are often single molecule drugs. They're replicable, they're consistent, they can be much more easily FDA approved. The vast majority of our FDA approved medications are single molecule drugs. Botanical products are challenging. They can be extremely complex. They can vary plant from plant. It is much more difficult to get consistency of hundreds of constituents, and there may be varying effects due to that entourage effect. There are significant regulatory differences between the two, and there are standardization challenges. Existing FDA-approved cannabinoids include dronabinol, which is a synthetic THC, also known as Mironol and Syndrose. Its approved use are nausea and vomiting related to chemotherapy and cachexia specific to AIDS. Nabilone is a THC synthetic, also known as Sesamet, is approved for nausea and vomiting related to chemotherapy, and cannabidiol is a highly purified CBD, also known as Epidiolex, that's FDA approved for very specific childhood seizure conditions. Our first question: which of the following are FDA approved cannabinoid medications? A, cannabis flower, concentrates, and edibles. B, endo, phyto, and synthetic cannabinoids. C, dronabinol, nabilone, Epidiolex. D, only cannabis products sold at any dispensary. And E, all cannabis products are approved. If you chose C, dronabinol, nabilone, Epidiolex, you are correct. Now we'll speak a little bit to cannabis and chronic pain with an evidence review. The tides related to medical cannabis took a significant turn when the National Academies of Sciences, Engineering, and Medicine published in 2017 the health effects of cannabis and cannabinoids. In this significant review, they concluded that in adults with chronic pain, patients who are treated with cannabis or cannabinoids are more likely to experience a clinically significant reduction in pain symptoms. And when comparing efficacy, it's extremely important. Chronic pain is a very diverse condition that within that falls neuropathic pain, non-cancer pain, refractory pain. Related to the evidence, here are 5 high-quality randomized double-blind control placebo trials that support the pain-relieving efficacy of cannabis, specifically in neuropathic pain. Evidence exists for the use of cannabis, medical cannabis, in specifically neuropathic pain. In this telling AMA Ethics Virtual Mentor publication, it revealed the numbers needed to treat for medical cannabis is only beat by tricyclics, specifically in painful sensory neuropathy. Many of the drugs that we utilize for painful sensory neuropathy have a greater number needed to treat than cannabis. And cannabis for refractory pain, it's important to define what refractory pain is. It's a chronic, severe, and treatment-resistant pain that doesn't respond to our usual methods. Several clinical trials show modest but significant improvements in pain, function, quality of life in patients with neuropathic, cancer, and other types of refractory chronic pain when utilizing medical cannabis. As usual, there are limitations and caveats. There's a need for more high-quality, long-term research in this area. Cannabinoids versus opioids for chronic pain is a very hot topic. We're going to look at comparative efficacy, comparative safety, and the opioid-sparing potential of medical cannabis. In a review of Medicare Part D done by Hockenberry in 2018, medical cannabis was associated with decreased opioids use. This included a decrease in opioid prescriptions by 2.11 million daily doses per year. Hydrocodone use decreased by 17.4%, and morphine decreased by 20.7%. Medical cannabis synergy with opioids in a study by Abrams et al. Showed a synergistic effect with opioids when medical cannabis was used, providing pain relief with lower opioid doses and with less side effects. And this did not change opioid blood levels. Another study showing a potential synergy with opioids, done by Benke et al., was an online survey of 244 medical cannabis patients with chronic pain. 184 patients were ultimately analyzed, and it found that cannabis was associated with a decrease in opioid use in 64% of those patients and an improved quality of life in 45. There are multiple types of clinical trials and observational studies. These include systematic reviews and meta-analyses that summarize the overall evidence on the efficacy and safety of medical cannabis for chronic pain. These include randomized control trials, as we spoke to before, that evaluate the efficacy of medical cannabis compared to placebo or standard treatments. There are observational studies that provide real-world data on the use, effectiveness, and tolerability of medical cannabis in chronic pain patients. And each and every one of these have limitations specifically in the realm of medical cannabis. Considering it is a Schedule I substance, there have been small sample sizes, short duration of research, variable product quality and formulation, a lack of consistency in the makeup of those products, and difficulty in blinding cannabis. Our test question number 2, studies have shown promise for medical cannabis in pain management in the following ways. Select all that apply. A, immediate reduction of acute pain. B, neuropathic pain. C, non-cancer pain. D, refractory pain. And E, potential for mitigating opioid reliance. If you chose B, C, D, and E, you were correct. Provider competencies in clinical settings, counseling on cannabis as a therapeutic. This is a very challenging area, considering that, as we noted before, medical cannabis is not an FDA-approved option. One of the counseling approaches that we consider very important with medical cannabis are harm reduction principles. Harm reduction is an approach focused on reducing the negative consequences of a behavior rather than eliminating the behavior entirely. There is marked importance in chronic pain management of harm reduction principles. Practical steps for clinicians when counseling on cannabis as a therapeutic are to include assessment, monitoring, patient education, and red flags. Very similar to any other medication or therapeutic option that we would offer as a physician or as a clinician. One of the most important roles we have as clinicians, as with other medications, is to identify best candidates for cannabis. Some that we've identified are patients with chronic neuropathic pain, especially those that are refractory or have tried usual therapies, patient with severe refractory pain along the same lines, those patients seeking to reduce opioid use that don't have contraindications or cautions, and patients with good mental health. Cannabis as an adjunct or mainstay in therapy. Multimodal approach is using cannabis alongside physical therapy, cognitive behavioral therapy, other medications, and this allows for a comprehensive and personalized treatment plan. This is the preferred approach to any utilization of pharmaceutical and much more medical cannabis. It is potentially can be used as an adjunct therapy using cannabis alongside other pain medication that could provide additional analgesic and anti-inflammatory benefits, sometimes from a separate mechanism of action, and can be used as mainstay therapy. And that's utilizing cannabis as a primary or mainstay in therapy for patients with pain that is refractory through other medications and treatment strategy. This is the least preferred approach. It is important with cannabis therapy to tailor it to the individual. That includes product selection, specific dosing strategies, and individualized titration. Medical cannabis can be extremely challenging for a physician. Unlike most of our FDA options, medical cannabis in the market as it exists can come in varying forms, from bud and flower to oral solutions to topicals, capsules, vaporized, distilled oils, tinctures, suppositories, oral sprays, wax, shatter, butter, and tablets. By far, as a physician, recommended forms usually are oral formulations. And it is extremely important for a physician, like any other medication, to note onset and duration of action when choosing delivery forms. Anything orally absorbed will have a slower onset of action and a longer duration, as we see with capsules with an onset of 1 to 3 hours and a duration of 4 to 24 hours. On the other end of the spectrum are inhaled forms that can have fast onset of action from 1 to 15 minutes and less of a duration from 2 to 6 hours, which oftentimes, if there is relief, means you have to dose more frequently. It's extremely important, as with any medication, to note the therapeutic window. Therapeutic window is that sweet spot whereby a therapeutic option will not cause side effects, yet will have the intended effect. And as we're speaking in this lecture, for cannabis, that would be pain relief. A fantastic article written by Bakker et al. Related to consensus recommendations on dosing. That article suggested that medical cannabis may be considered for neuropathic, inflammatory, nociplastic, and mixed pain, and they offered 3 treatment protocols. A routine protocol that starts with CBD, titrating up to 40 milligrams per day before adding THC, a conservative protocol with a slower CBD titration and a lower initial THC dose, and a rapid protocol that starts with a balanced THC-CBD ratio and titrates both simultaneously. Due to the complexity of the cannabis plant, it's extremely important to engage safe dosing strategies. Starting doses for pain, you should begin with the lowest dose possible. I've seen studies as low as 1 milligram THC. More common starting doses are from 2.5 to 10 milligrams THC, or 10 to 20 milligrams CBD. We need to assess individual tolerance very closely when making these decisions. Starting doses prior to sleep include initiating with a little bit higher dose of THC from 5 to 20 milligrams, from 20 to 40 milligrams CBD, and ideally taken 1 to 2 hours before bedtime. Titration tips are extremely important, that you go slowly. Start low, go slow, stay low, and gradually increase that dose every 3 to 7 days until you're achieving those desired effects without side effects. It is extremely important with cannabis as a therapeutic to start low, go slow, and stay as low as possible. For THC, that often means starting as low as 1 to 2.5 milligrams by mouth in the evening and increase by 1 milligram after 2 to 4 days, with a reminder of that half-life of THC. CBD to be utilized as a cushion, starting 5 to 25 milligrams once daily and increasing by 25 to 50% after 2 to 4 weeks, and waiting between doses to gauge the reaction of the patient and to achieve that desired effect without unwanted side effects. And again, a reminder that it could take 10 to 15 minutes for an inhaled product to take effect and 90 to 120 minutes for edible products to take effect. Again, it's extremely important for physicians to be reminded that dosing is extremely different between these delivery forms. A puff on flower could be from 1 to 10 milligrams THC, depending on the potency. A puff on a vaped concentrate could be 2 to 5 milligrams THC, depending again on the potency. And edibles, usually approximately 2.5 to 5 milligrams. One must look very closely at the label of the product to ensure what that dose is and to be able to speak intelligently to patients utilizing medical cannabis. Our third question here, starting THC dose for a cannabis naive patient is 2.5 to 5 milligrams THC, which equates to about A, 1 full joint, B, 5 pulls off a vape pen, C, 1 or 2 10 milligram gummies, D, 1 small puff of a joint or pen or half of an edible, and E, cannabis is safe and comfortable at any dose. D is the correct answer. Obviously not E. And again, dosing is extremely important to get right to prevent unwanted side effects for our patients. Provider competencies in a clinical setting, speaking to counseling on cannabis treatment risk. Medical cannabis contraindications. Absolute contraindications include acute psychosis and other unstable psychiatric conditions. Relative contraindications include severe cardiovascular, immunological, liver or kidney disease, and especially in acute illness. Cannabis may also exacerbate arrhythmias or someone with a history of arrhythmias. Drug interactions are also a concern. Cannabis may enhance CNS depressant effects when combined with alcohol, barbiturates, benzodiazepines, but likely not opioids. THC induces CYP1A2 and can reduce levels of drugs metabolized by CYP1A2, and CBD inhibits CYP3A4 and CYP2D6, can increase levels of drugs metabolized by these isoenzymes. CYP3A4 metabolizes about a quarter of all drugs. Adverse effects and safety. We have to be very careful with psychiatric risks. Medical cannabis has the potential to exacerbate pre-existing mental health conditions such as anxiety, depression, and psychosis. Cognitive impairment, it can have temporary effects on memory, attention, and executive function, especially with acute use. And physical risks, respiratory irritation when smoked or vaped, increase in heart rate, potential for drug interactions, impaired coordination causing accidents, driving, potentially falls in elderly and disabled, and acute toxicity, especially for small children. In special populations, we have to be extremely cautious with adolescents, increased risk for those initiating use under 25 years of age because the brain continues development up until 25 years of age. Those with severe mental illness, we must carefully evaluate and ultimately likely avoid medical cannabis, but looking at risks and benefits in patients with schizophrenia, bipolar disorder, and other severe mental illness. Substance use disorder, we must assess the risk of exacerbating or triggering substance use issues when considering medical cannabis. The elderly have unique pharmacokinetic and pharmacodynamic considerations, increased vulnerability to adverse effects. We have mentioned in a few. Postural hypotension is another one. And pregnancy, potential to increase behavioral issues later in life for the unborn child, increased risk to the fetus, and THC passes through breast milk. We should absolutely avoid any THC in pregnancy. And again, we should avoid cannabis with any patient with a psychiatric history, any patient with a substance use disorder, and other contraindications. Those drug-to-drug interactions, as I mentioned, pregnancy and breastfeeding, adolescent use, and others. Medical cannabis dependence rates are around 9%. And again, in comparison with other substances that are regularly available, many of them, even in an open market, if you are of the right age, this is a lower rate, but 9% is still a dependence rate that exists, and we need to speak to that as clinicians. And when speaking to an LD50, this is one of the reasons that I have approached medical cannabis as a physician myself, was a reassurance of an extremely high LD50. And by a very wide margin, cannabis is the least risky recreational drug. As far as I know, there is no known case of a lethal toxic overdose of medical cannabis. That doesn't mean that someone may be at risk for side effects or other things that may happen when under the influence of cannabis. The lethal toxicity of medical cannabis is nearly non-existent. Responsible use versus misuse. As clinicians, we must recognize signs of problematic patterns, increased tolerance, cravings, impairment in daily functioning. We must distinguish responsible use from misuse, using cannabis as directed for therapeutic purposes, as we would with any other medication, and using it in a way that avoids leading to negative consequences. And as clinicians, when we interact with a patient, whether under our recommendation or not, we must monitor for changes in behavior or function, mood, cognition, and ability to carry out daily activities. A good reminder is the SBIRT framework, screening and the utilization of validated tools, which include CUDIT. And this should be for all individuals in which we try to detect concerns. A brief intervention, an evidence-based intervention that includes motivational interviewing, cognitive behavioral therapy, and contingency management, giving feedback on use, and a collaborative approach to health and behavioral goals. And if someone meets criteria for moderate or severe substance use disorder, brief interventions are not producing change, we should refer for treatment. These include specialized addiction treatment centers, including outpatient and or residential programs. We should not make the same mistake with cannabis that we have made with opioids in the past. And we should be aware of the dependence potential of medical cannabis and monitor closely. SBIRT risk stratification example includes a pre-screen, which includes a full screen if it's positive. If it's mild to moderate, there could be a brief intervention that includes medications and behavioral. Moderate to severe may include clinical assessment and referral to treatment. If it's low, there may be brief advice. If it's negative in terms of that pre-screen, we reinforce those healthy decisions and we continue to monitor. This risk stratification example reinforces the importance of ongoing monitoring of any substance a patient is utilizing with dependence potential. This is an example of the QDIT-R. The QDIT-R summary, it measures problem cannabis use in the past 6 months. A score of 8 or more indicates hazardous use. A score of 12 or more indicates the need to assess for cannabis use disorder. The PRISM-5 is a highly reliable computer-assisted clinical tool suitable for comprehensive diagnosis based on DSM-5 CUD criteria. One thing we like to reinforce is the importance of person-centered care. And that is what I've tried to exercise my entire career as a physician, where the patient and the provider are a team. There are important habits that we must employ to support the whole person. We must always validate patient efforts and strategies. We must employ brief interventions, try doing this versus don't do this, and exercise motivational interviewing. It is always important to collaborate on small next steps. Brief intervention, counseling on long-term effects, important to discuss habitual cannabis use. It's important to discuss potential cognitive effects, and it's important to discuss recovery resources. Counseling patients with mental illness, it's extremely important to recognize potential risks, to discuss potential benefits cautiously, and to communicate openly and empathetically with our patients. It is incredibly important to recognize the addiction potential and the potential for cannabis use disorder, to identify risk factors that include individual, environmental, and genetic factors that increase the risk of developing CUD, and to understand addiction criteria, the diagnostic criteria for cannabis use disorder according to the DSM-5. Potential referral to treatment with a DSM-5 CUD criteria include withdrawal, tolerance, increasing quantity or frequency of use, longer episodes of use, persistent desire or unsuccessful attempt to decrease or control use, a great deal of time spent obtaining, using, or recovering from effects of cannabis, social, occupational, or recreational activities given up or reduced because of use, continued cannabis use despite knowledge or causing exacerbating a medical condition, recurrent difficulties to fulfill major role obligations, recurrent use in hazardous situations, craving strong desire to consume cannabis, and continued use despite interpersonal problems caused by cannabis use. While not extremely common, I would be remiss to not mention the syndrome, cannabis hyperemesis syndrome, becoming more and more common as cannabis use is more prevalent. Cannabis use syndrome has a classic triad: long-term frequent cannabis use by the patient, cyclic vomiting and severe nausea, and pathognomonic, or what truly identifies this disease, is simply the question: do you get symptom relief with hot showers or bath? If the answer is yes, it is extremely likely to be cannabis hyperemesis syndrome, and there is no clear treatment for this. The patient must seek another therapeutic option rather than cannabis. One more exam question here. You screen a patient for cannabis use disorder using cannabis use using the QDIT-R at an annual checkup. They score a 12. What do you do? Please select all that apply. A, you criticize them for their cannabis use. B, you move on with the visit. It's probably fine. C, you recommend patient complete the PRISM 5. D, you refer the patient to rehab immediately. E, you counsel the patient based on their unique situation. If you answered C and E, you are correct. We should recommend that the patient complete the PRISM 5 diagnostic tool, and we should learn more about the patient's use and counsel the patient with person-centered care principles. A few final things to consider. The legal status of medical cannabis. Under federal law, cannabis, as I mentioned at the beginning, remains a Schedule I controlled substance under the Controlled Substance Act. State laws vary, but increasing legalization of medical and/or recreational cannabis has been occurring for years. There's a state-by-state patchwork of varying regulation and policies that both patients and providers must be comfortable with and well aware of. There are multiple discrepancies between states that can create challenges and uncertainties for healthcare providers. Prescribing versus recommending. As a Schedule I substance, physicians cannot prescribe medical cannabis. They are allowed to only recommend. Documentation requirements are very similar to any other pharmaceutical or medical therapeutic that we would recommend. There are potential liability considerations for medical cannabis that may not exist with other FDA-approved therapeutics. Patient counseling and documentation. As with any other therapeutic option, it is extremely important to document informed consent, ensure patients understand fully the risks, benefits, and legal considerations of medical cannabis use. It is extremely important to address affordability and access. Providing guidance on navigating insurance coverage. Vast majority of medical cannabis products in no way are covered by medical insurance, financial assistance programs, and specifically legal access to medical cannabis. A number of key takeaways from the lecture today. Cannabis is not a panacea. Yet medical cannabis does not kill. We have no known cause of death from lethal toxicity of a cannabis overdose that has been reported. Research on benefits is in its infancy. As medical providers, as clinicians, we need to keep tabs on medical cannabis and the research that is exponentially growing by the day. It is an effective treatment, specifically in chronic pain. Neuropathy has the highest quality evidence. Medical cannabis has the potential to work synergistically with opioids. It has a well-tolerated side effect profile. And it is important that the medical community, not the cannabis industry, be a pillar of education and support for patients surrounding medical cannabis as a therapeutic option and the endocannabinoid system. And the treatment of chronic disease, in my opinion, requires a paradigm shift that single modalities should be used in combination, specifically in chronic pain, to minimize chances for dependence, for addiction, and to maximize positive outcomes for our patients. In all of my lectures on medical cannabis, it is important to me, despite the quote that the plural of anecdotes is not evidence, to share a case of patients. And this is a patient that I worked with directly, who was markedly positively impacted by medical cannabis. She carried a severe diagnosis of transverse myelitis, and shared with us that she learned to live on her own again. And I'm proud to share to anyone that will listen that cannabis has given me the miracle I was waiting for. And again, not to say that cannabis is a miracle drug, but to reinforce the nuance that is involved in clinical care and to utilize tools to the best of our ability as clinicians, including medical cannabis. Thank you for your time today. I really hope that this was informative to you and helpful. It is extremely important that we all are more knowledgeable related to medical cannabis. It is a pertinent topic that will only increase in the future. Contact information for the Comprehensive Center for Pain and Addiction. The email is painandaddiction@arizona.edu. The website is seen there below. I am very appreciative of your time, and thank you for your attention today.